Welcome today to our topic of malaria in Haiti. Malaria is the most important of all tropical parasites that you'll study. It causes more deaths and more morbidity than any other parasite in the world and is responsible for millions of deaths a year in third world countries. It's widely distributed in tropical and subtropical zones. And although there are 4 parasitic species of malaria, in Haiti we're going to restrict our talk to Plasmodium falciparum, as it exclusively is the only agent that causes malaria, or that's been reported to over the past several years. Last year it was responsible for 100% of the reported cases, of which there were 30,000. It is believed, however, that there are probably an annual infection rate of 200,000 cases per year. The biggest time of infectivity is after the rainy season, which can occur between November and January, making after January a particularly high time. And there is a rainy season from May to June. Which would then account for a higher incidence. It was felt that after the earthquake, because of ruptured sewer mains, along with overcrowding and people living more outdoors and being exposed to the nocturnal bites of the Anopheles mosquito, that the incidence might go up. And although there was some increase, it wasn't as dramatic as expected. The incidence of malaria in Haiti is about 4.7% annually. Although it's endemic, there is somewhat of an unstable transmission rate. The vector for malaria in Haiti is the Anopheles albinumus mosquito. In the southern portion of Haiti, there has been some concern about a new vector, an Anopheles species called Puncta peninus, as causing some new cases. There has been no resistance to chloroquine in cases of malaria in Haiti, which is good news, as chloroquine is both effective and inexpensive. So with no resistance, it has certainly remained the drug of choice. The highest case incidence of malaria in Haiti is along the coastal regions and in the rice growing areas. The Atibabite Valley certainly represents the highest incidence of malaria in Haiti. I thought we'd begin with examining the life cycle of malaria. As you know, malaria is usually transmitted by the bite of an infected female Anopheles mosquito, and in this case we know our species is albinumus. The infectious agent is a sporozoite. These sporozoites live in the saliva of the mosquito, right in its parotid gland, and with the bite of the mosquito, thousands of sporozoites are injected into the human host. These sporozoites, though, are going to disappear real fast. In about 8 hours, they're cleared from the blood because they've made their way, if they've been able to the liver. Those that survive get to the liver and into the liver cells. And inside the liver cells, these parasites multiply asexually in a process that we call sugony. This process of schizogony can take place both in the liver and as your liver cells, the hepatocyte, and as you're going to see later, the red blood cells as well. Once they're inside the liver cell, the sporozoite, as it divides asexually by fission, will form a cyst-like structure, which we're going to call a schizont. A schizont will contain tens of thousands of merozoites. These merozoites are very small trophozoite type particles with nuclear chromatin and a small cytoplasm. And eventually, the schizont, as it matures, ruptures. And when it does, as you can imagine, it liberates all these merozoites. These merozoites now flood into the bloodstream, and they're going to penetrate the red blood cells. The time that lapses between the bite of the infecting mosquito and the appearance of the parasites now in the blood in the condition of Plasmodium falciparum is about 10 days. So from the time they inject the sporozoites until the time that these merozoites release from the schizonts in the liver that invade the red cells is 10 days. There is a special case. We probably will not encounter it, but for learning purposes, only in the case of Plasmodium vivax and ovale are you going to get that hepatic stage parasite that persists in the dormant form that you learned about in school called the hypnozoite. That's when there's a dormancy of the schizont. It doesn't rupture. Replication goes on after a period of months or years, and at that time, relapses can occur months, even years later. Well, we're back to where the merozoites have been released in the bloodstream from the schizonts, and now they've attached themselves to red blood cells by means of surface receptors. What happens then is the parasite penetrates the red cell after it attaches, and then it resides in a vacuole that has been formed from the lining derived from the red blood cell surface. It's kind of like it hits a bubble. As it goes in, the bubble breaks off, and now it's floating around in a little vacuole. And here inside, this parasite's going to grow, and it's going to feed on the hemoglobin of this erythrocyte. After about 24 to 36 hours, it's going to begin a second episode of asexual division, and this is called the blood schizogony. So this is the second time of the division phase, first in the liver, now in the red blood cell. This time, instead of tens of thousands of merozoites, there are roughly about 12 to 24 merozoites per infected red cells. In falciparum, this schizogony only occurs in the red blood cells that are located in capillaries. And these capillaries are within the tissues of the body. As they mature, the trophozoite, these antigens of this parasite, the merozoites, are expressed on the surface of the red blood cell. Some of these antigens are capable of linking to receptors that are expressed on the endothelial lining cells in the capillaries. So now you're going to, because of an antigen reaction, get these erythrocytes clinging to the endothelial lining of the capillaries within tissues, and this causes a certain cytoadherence of these parasitized erythrocytes to these endothelial surfaces, and with that you're going to get a gathering of these infected parasitized cells, which is going to cause some ischemic or sludging or circulation problems. There is a periodicity of the schizogony that's characteristic of malaria, and for that reason malaria in fables, but I guess in reality as well, and no one knows why there is a synchronized schizogony, but it's caused people to look at malaria as something that has a periodicity of fever that would come every 3 to 4 days, and that can be the case in a perfect scenario, and they used to call that tertian malaria that would happen with vivax and ovale, where subtertian malaria really occurred a little more often than every third day, which was seen in falciparum. But believe me, I think what that led to was that in the past many patients lost their lives from falciparum malaria because they never developed this periodic fever that the doctors believed was an invariable part of a diagnosis of malaria. So we're not going to be looking for that. some of the merozoites entering red cells do not develop into schizonts, but develop more slowly into solid-looking parasites called gametocytes. So now you have the sexual form of division. These persist in the circulation for many weeks and do not destroy the red cell that contains them. They are the forms of which the infective that the mosquito will digest when he has his next human blood meal. And from that, the sexual process will go on as there are both male and female counterparts to the gametocytes. One in the male is analogous to the sperm, and in the female analogous to the egg. And when they're digested by the mosquito with a human blood meal, they will maturate in the stomach of the mosquito, where the gametocyte will then form a nucleus for offspring of sporozoites, which will then travel up the GI tract into the parotid gland, where they're ready for the next infective stage of the human, and the cycle is completed. Well, let's move on to the clinical features of malaria. There are no recognized symptoms associated with the liver stage of the malarial infection. Symptoms really do not begin until the schizonts rupture in the liver, and the merozoites are released into the bloodstream and penetrate the red blood cell. And as we said in falciparum, this takes about 10 days. So about 10 days after the inoculation of a mosquito bite with the sporozoites, one can develop symptoms. There's infections. There are certain symptoms that are common to all strains of malaria, and these result from the release of toxins and pyrogens that happen when the red cell ruptures. These common features of malaria are fever, anemia, splenomegaly, and jaundice. The jaundice is a mild jaundice. It's caused by the hemolysis that occurs with the rupture of the red blood cell. In falciparum, there can be some impaired liver function due to some sludging of the capillaries to the liver. The fever, which is the prominent feature of malaria, is often irregular. It is believed to be mediated by cytokines, which are secreted by leukocytes. The pattern of regularity of the fever often does not occur until the illness has continued for quite some time, and then it develops that synchronized schizogony that we talked about. The anemia, on the other hand, is multifactorial, as it's a combination of both hemolysis and bone marrow suppression that occurs from cytotoxins. The hemolysis is more severe in falciparum infection. And then the splenomegaly really begins very early in the acute attack of malaria, as the red cells, the damaged red cells that have been lysed, are removed through the reticular endothelial system of the spleen, and with that enlargement. The spleen might have enormous size in the hyperimmune syndrome of hypersplenomegaly, which we will talk about later. The stages of fever in classic malaria goes through a first stage, where there's a cold stage where the patient has is shivering or has frank rigors. Right after that, the temperature is going to go up and spike high, 103, 104, sometimes higher in kids. And during that time, there's a really rapid pulse. And this is followed by a sweating stage where there's profuse sweating. The temperature falls rapidly. The flushing from the high temperature is over, and there might be some hypotension. These are stages are often recognized more often in some of the more synchronized malaria, such as Vivax and Ovale, and not so much in falciparum, where our attention needs to be focused. I think the pearl to take away from this is that an individual with a symptomatic malarial infection or even with severe disease may be afebrile at one particular time. History of recent febrile illness or documented with repeated measurements of temperature might be needed to implicate fever. Let's look at the progress of untreated attacks which lead to chronic malaria. The natural history of untreated malaria is going to differ for each species, and for our concerns, we're going to stay focused on falciparum. Following a single exposure to falciparum, the patient will either die in the acute attack, and thank God that outcome is in a minority of infections, or otherwise the people will survive with the development of some immunity with some residual anemia as well. So you're going to get a population that's gradually developing immunity and having some residual anemia. These attacks are going to reoccur over the course of the next year. If they're untreated, they continue, but they die out spontaneously in the absence of any reinfection. All right. So you can have a recurrence of a malarial illness, and this can either be recrudescence if it's caused by persistence of the blood forms in small numbers between attacks, or it can be a reinfection when it's due to a new inoculation by a mosquito who's dumping the sporozoites back into the human vector. But if no treatment is given to clear the blood forms of the parasite, recrudescence may occur from time to time, and this can go on for years. In fact, in falciparum, even more than 10 years. The severity of the attacks, however, as they go on, get less and less as more and more immunity develops. And often by the time we see people like this that have lived there for years, the fevers last but 2 to 3 days tops. And the illnesses are limited to flu-like illness of fatigue, body aches, and headache. We should probably familiarize ourselves with some of the peculiarities of the falciparum infection. Falciparum differs from other Plasmodium species that infects humans in its capacity to cause severe and complicated disease, and therefore it's really the major feared species variety. Nearly all of the million or more malarial deaths that occur each year result from this species. If the area tends to be endemic, most of the clinical impact of falciparum infection falls on young kids. It's young children that you're worried about. Even when children reach 5 to 6 years old, they've developed in endemic areas enough immunity where they do not have the fatal complications. Nevertheless, the majority of infections, no matter who you are, cause only a self-limited febrile illness or an illness, or as the immunity increases, some people will have no illness at all, even though they carry malaria in their bloodstream if they were to be tested. For reasons that are still not understood, some infections do progress to severe disease and are fatal. These are usually to areas that are have unstable transmission. They can occur in both adults and children with falciparum, and these complications can occur in either a group, especially if the diagnosis is not picked up, medicines are not available, things are delayed. Complicated falciparum is also known as severe malaria and takes its form in different ways. There are probably 5 different clinical syndromes that occur particularly in young children that we need to be aware of, that happen in endemic areas and will be present in malaria in Haiti. And these are prostration, severe anemia, cerebral malaria, acidosis, and hypoglycemia. And a child may suffer from one of these complications or any combination of them. Other complications can be seen in adults, but these are usually due to immunological reactions and due to other strains of malaria. So for all practical purposes, I think we're looking at these 5 general specific syndromes of falciparum. Any child with these conditions need to be recognized, but probably are going to, because of the severe nature, are going to need IV quinine as part of their treatment. So they're going to be taken to a hospital. But from the standpoint of education, I thought we'd go over them. If you were to run into a young kid with severe altered consciousness or coma, in children, we have to look for the fact that they could have hypoglycemia or acidosis, and we want to check for those and correct them. We look for a glucometer. If indeed the sugar is low, we want to give D50W and hydrate the patient, and the same for acidosis. They will respond with volume expansion. The other thing we got to think of when we see someone unconscious or in coma, we look for the minimal amount of activity. Even slight twitching may indicate that they're having a seizure disorder and are in status epilepticus, and at that point the administration of anti-seizure meds, either rectal Valium or IM phenobarbital, might be called for. Severe anemia might also impair consciousness. This usually won't happen unless the hemoglobin level is going to fall below 4. Once you administer schizontocidal drugs, the hemoglobin really improves dramatically, and transfusions are usually not given unless the hemoglobin is at least less than 5. Sometimes when you find a patient with altered consciousness and you do not find that they have a seizure, they're not anemic, and they do not have hypoglycemia or acidosis, yet they have malaria, you need to think of other causes of altered mental status, such as meningitis, encephalitis, a severe pneumonia with septic shock, or possibly a head injury. So let's look at these other complications as we looked at just prostration. Let's look at cerebral malaria. What is it? Basically, it's defined as a disturbance of cerebral function characterized by altered consciousness and accompanied commonly by convulsions. Usually the onset is gradual, though it might be sudden, can occur within days, usually starts after 1 or 2 days of fever. It is not uncommon for a child with cerebral malaria to become comatose. This might be, coma might be accompanied by flaccidity of the limbs, or they might be hypertonic. There might be posturing, as in opisthosis, with their neck hyperextended and their body hyperextended. Any repetitive muscular contractions, even a minor degree, should suggest seizure activity, and the introduction of medications for the latter. Recently, there's a characteristic retinopathy that's been described that is somewhat diagnostic of cerebral malaria. If you happen to have a mydriatic there and can dilate the pupil, then with the direct ophthalmoscope, if you're decent at it, you're going to look for retinal changes, which they'll turn white, specifically around the area of the fovea, which will not be involved. There'll also be orange or white discoloration of the retinal vessels. These features are distinctive and very helpful in diagnosing the condition of cerebral malaria. It's said that about 10% of kids with cerebral malaria will have papilledema as well. The coma might persist despite a correction of metabolic defects and seizures, and no other explanation can be found. In this case, they indeed have cerebral malaria. If you give them anti-malarial drugs together with supportive care, about 80% will recover from this. Usually, within 1 to 3 days, the coma will end. However, probably 5 to 20% of people are left with a neurological deficit, but even of those, a good 50% of those will have their deficit resolve over the period of 3 to 4 months. Some, however, do suffer subtle continuous impairments of memory and intelligence. What is the pathogenesis of cerebral malaria? Still unclear. Obviously, it was thought that there might be some plugging of the microcirculation with total obstruction due to sequestered parasites in the bloodstream with its propensity for cytoadherence to the endothelium of blood vessels. But if that was the case, then irreversible brain damage should occur, and that doesn't. So it probably what happens is the highly active developing and dividing parasites may consume a lot of the nutrients, particularly glucose, and these cells might release toxic products, including lactate, that are detrimental to the surrounding tissue. When the schizont ruptures, the red cell substance that are known to stimulate the release of cytotoxin from host cells are released, and there's excessive local and systemic concentrations that might contribute to the coma. The third complication that we want to go over is severe anemia. It's most common in children between 6 and 24 months of age. Again, more intense with falciparum. It's due to the direct red cell destruction when the schizont ruptures. There's also further hemolysis, both of the parasitized and unparasitized erythrocytes due to autoimmune mechanisms due to the cytokines that have been produced. Red cell destruction or hemolysis is not the whole story. Otherwise, we'd see a rapid reticulocytosis going along with the hemolysis, and we don't. Therefore, bone marrow biopsies have proven that there is suppression of bone marrow function, as their hypocellular marrows seems to be mediated again by cytokine response. This severe anemia may lead to shortness of breath and sometimes acidosis. Let's look at acidosis. Acidosis is a result of tissue anoxia, just due to the low hemoglobin, of the oxygen carrying capacity of the red cells now reduced. Also the ischemia due to the sludging of the blood vessels due to the endothelial adherence of the parasitized cells. And now you have anaerobic metabolism with the release of lactic acid. And this acidosis is initially compensated for by Kussmaul, or rapid breathing. However, eventually one will not be able to keep up to this, and the arterial pH will fall. The parasitized red cells, which may impair tissue perfusion, along with the anemia, the hypovolemia, and the hypotension, are all culprits in this. And as a result, fluid replacement might be life-saving. Whole blood might also need to be entertained. The fifth complication would be hypoglycemia. It's a common complication in, again, children with malaria, and we're talking about kids less than 5, those who have not developed immunity. It can occur in adults, and particularly has a propensity for pregnant women. The principal mechanism of the malaria of the hypoglycemia is probably a cytokine-induced impairment of hepatic gluconeogenesis, as there's no nocturnal turnover of glucose due to the cytokine suppressive effect on either glucagon directly or the hepatic cell release mechanism. Then there obviously is the consumption of glucose by all these parasitized red cells, and then hypoglycemia sometimes might develop as a complication of quinine therapy, as quinine probably produces insulin by stimulating pancreatic beta cells to do so, and pregnant women are particularly susceptible to this, and yet quinine remains the drug of choice for severe malaria, both in adults and children, and even in uncomplicated malaria is the drug of choice for pregnant women, as it has a safety factor that goes beyond that of other medications. An unusual complication of malaria that we'll mention is black water fever. It's pretty much become obsolete. Usually occurs when it does with falciparum, when there's severe intravascular hemolysis. As you know, haptoglobin levels fall because of the binding of the hemoglobin, and then the excess hemoglobin will eventually come out in the urine, and you get hemoglobinuria, which, when seen in the face of quinine, often will lead to a black color in the urine. It's usually seen in non-immune adults. In some cases, or most cases, that really do happen, this hemoglobinuria is precipitated by a drug, as we mentioned, such as quinine or primaquine, or some dietary measure in those individuals, usually males with glucose 6-phosphate deficiency. And this hemolysis in this situation is usually so severe, only affecting older red cells, and it will cause a great amount of free hemoglobin that will be seen in the urine. All right, I'll try to stop the odds. Let's look at pregnancy and malaria. This can lead to abortion. Falciparum infection, even in normally immune women in pregnancy, is associated with the likelihood of developing a high parasitemia, especially if it's the first pregnancy. Because anemia is so common consequence of the women entering labor in these countries, the low hemoglobin concentration, when you add the parasitemia, causes the peripartum blood loss to be actually somewhat dangerous. Falciparum really leads to low birth weight children, especially first pregnancy babies. These present an increased risk of dying in infancy because of this low birth rate, presumably from the fact that the placenta becomes packed with both the late-stage parasites and the host cell's mononuclear response to the infection, causing poor placental blood supply and therefore low birth weight babies. Let's talk about the immunity in malaria, and thank God for it. Immunity in malaria is most pronounced in falciparum infection. In areas with a very high transmission, if a child survives to the age of 5 or 6, she's likely to have, he or she is likely to achieve the high degree of immunity, so the lethal effects of the infection are not going to occur. The immunity has a couple components. There's an ability to limit to the parasitemia as the patient develops a protective IgG antibody, and also an anti-parasitic immunity due to the development of a cell-mediated immunity. But there's also an additional physiological tolerance to the parasitemia, as the parasites, as we know, produce cytotoxins that cause fever and cause surface receptor attraction, and the person can develop an antitoxic immunity as well. In order to maintain this immunity, however, we need to have the patient needs to have frequent re-exposure to the infection, often several times a year. If this does not occur, they're going to lose their immunity. These cases were seen in students that would travel from East or West Africa to Europe, go away to school for 3 years, then come back to their homeland and find out that their immunity had gone and the malaria again when they got it was severe. The development of a high degree of immunity in an entire population exposed to high levels of Plasmodium falciparum has an extremely important effect on this epidemiology. What do we also know? We also know that if a CD4 count falls in an individual with HIV infection, they really get susceptible to Plasmodium falciparum, as you would expect. They develop a greater density of parasites in the peripheral smear than a person that would be immunocompetent. However, it hasn't been shown that they're more susceptible to severe anemia. But what does happen is that their viral load of the HIV gets higher when they have malaria. Also known as HIV positive pregnant women are more likely than others to have malaria in pregnancy, and are more likely to not clear with standard treatment. There is some thought also, and studies show, that when a woman with HIV is having concomitant malaria, that the chances of transplacentally passing the HIV infection to their child is increased. There are some other protective factors in malaria. You probably read a lot of stuff about that, and some of it's true. Individuals with sickle cell trait are resistant to the lethal effects of Plasmodium infection, but no more resistant to infection itself. The reason they don't get the severe lethal effects is that the sickle cells that would harbor the schizants are removed from the circulation before they have time to develop into numerous merozoites, which would increase the high parasitemia rate. Therefore, they have a lower level of parasitemia due to the early removal of sickle cells by the spleen. There's probably a similar effect with glucose 6-phosphate deficiency, but it's less striking than happens with sickle cell trait. If someone with sickle cell gets this, there is no protective effect, and obviously the combination of the two hemolyses are drastic, and the bone marrow depression from the cytotoxins of malaria in itself can be lethal. Some complications of malaria are related to its immune effects. However, with falciparum, the only one that we'd be concerned about would be the hyperreactive malarial splenomegaly. It used to be known as tropical splenomegaly. In this case, there's mock splenomegaly. This is where you get your giant spleens that can go all the way down the iliac crest. It's due to the infiltration of the hepatic sinusoids with lymphocytes. There's usually a high circulating level of IgM. This condition usually will resolve if you can leave someone on continuous chemoprophylactic medication, sometimes for up to 2 to 3 years. Interventions against malaria, such as bed nets and so forth, have proved that if one can diminish the incidence rate of malaria, that mortality in general from other causes falls as well, including respiratory infections. This suggests that malaria in itself has an immunosuppressive effect that causes susceptibility to other common pathogens. An example of this, and there's been some interesting studies on the immunosuppressive effect that a malaria may account for the tendency of the Epstein-Barr virus to produce Burkitt's lymphoma, where there's malaria endemic areas. People are more prone, they get Epstein-Barr, which we know is sometimes a precursor of Burkitt's. So how do we make this diagnosis? If we don't have a microscope, we're in trouble unless we get one of these new rapid diagnostic tests, or RDT dipstick tests, and I'm hoping that we're going to have them. The old-fashioned method and the reliable method is direct diagnosis, where you use thick and thin slide. The thin slide, blood slide, is very good for really noticing the parasite morphology in order to have species identification. Well, we already know that in malaria, 100% of the time in the last few years, it's always been falciparum. So that's not going to be too helpful for us. Again, we're probably not going to have a microscope. The thick films would surely be able to pick up the parasites more readily than the thin film, as they're more numerous on the thick film. Serological diagnosis with antibodies are not helpful. It's kind of analogous to those with H. pylori. Once positive, always positive. So those kind of tests are not of any advantage, as almost the whole population has been exposed. The rapid diagnostic tests, however, are quite interesting. They have the advantage of not requiring a microscope, and they require less training than microscopy. They are very sensitive in the detection of falciparum, and what they actually pick up some of the cytokines and antigens of the falciparum species. So let's talk about, as we end the treatment, let's also in the treatment discussion talk about prophylaxis, and then let's finish with prevention. The treatment of a patient with malaria might be supportive if we had a severe case. We got to think about reducing temperature, the use of Tylenol over aspirin, what we call paracetamol, tepid sponging for those temperatures that might be up high to 103 or 104, and certainly rehydrating with replacing of fluid. Likewise, we need to treat any type of activity in those with altered consciousness that is suggestive of a seizure with rectal diazepam or intramuscular phenobarbital. I think we need to be alerted to the effect of acidosis for volume replacement and hypoglycemia to be able to give D50W. In terms of specific chemotherapy, we are in a chloroquine sensitive area, and so we will be using chloroquine, but just for discussion sake, there is specific treatment directed at terminating parasitemia, and it needs to be done as rapidly as possible. Drug resistance, as you know, is an increasing problem throughout the world, and we're starting to use combination therapy, especially if any of you has ventured to Africa. For the first-line treatment of uncomplicated malaria or other drugs for treatment of failures or of severe disease, you've got to use combinations. Basically, what's happened is we're using art therapy or artemisinin combination therapy ACT. A lot of countries now have a national policy and will have specific drugs that they intend for you to use, and if that's the case, you should use them. Basically, one treats non-severe malaria with oral drugs if people can take them, and complicated Plasmodium falciparum requires parenteral anti-malarial drugs, at least till the patient can swallow. And up till now, most of the time, that's been quinine, now used sometimes in combination with trovaquone. Some of the schizanthicides also will have anti-inflammatory effects. The most widely used schizanthicide up till now has been chloroquine, but as you know, because of chloroquine resistance, the drug has had limited use, but for our sakes, it is still useful in the Caribbean. Chloroquine remains the drug of choice, though, for non-falciparum species, and in our case, certainly in our area, we're going to use it. A word on artemisinin. They're playing an increasing part in malarial treatment, both in combination with a partner drug as part of first-line therapy, also known as artemisinin combination therapy. Parenteral quinine remains in widespread use in Africa, and actually even here in Haiti for severe malaria. Chloroquine. Let's look at our treatment. Our treatment for chloroquine in adults will be, we're probably going to get 300 milligram tablets. They're going to take 2 to start. 6 hours later, they're going to take another one, and then 1 a day for 2 more days. It's pretty easy treatment. So 600, 300, 6 hours later, 600 the next day, and 600 the day after that. So basically just a little more than 2 grams. If you had children here involved that we're treating with chloroquine, then it's 5 milligrams per kilogram with a maximum starting dose of 300 milligrams. A child is considered an adult when they weigh up to 60 kilograms, in which case they need to be treated as such. Some of the things to be aware of with the use of chloroquine, some of the common side effects are malaise, headache, myalgias. There is some nausea and even some vomiting. With chronic use of the drug, taking it for a long time, some people have developed some vitamin A deficiency with some nighttime visual difficulties. In black skin people, a very common complaint is going to be a generalized itching. The course, though, is very short, only lasting a total of 3 days. Sometimes it's better to just have people put up with it. Other than that, there is rarely a hypotension that can be seen with it. Moving onward, let's move on to chemoprophylaxis. This involves regular administration to prevent clinical symptoms. Drugs taken for this purpose act in 2 ways. They could be schizanticides, so that when the parasite enters the red cells, they are destroyed. And then there are casual prophylactics, which prevent the development of the hepatizant, or the schizant in the liver. Or they might have both effects on the blood and hepatizant. Currently, chemoprophylaxis is routinely advised only to non-immune travelers visiting endemic areas. Haiti is considered an endemic area, and particularly we're going to a coastal area up north where the incidence is higher. Usually the prophylaxis requires assessment both of the risk and the potential benefits. The thing is, we are going at a time when the incidence is not high. Basically, chloroquine could be used, but drugs that probably make more sense under consideration would be taking Malarone, a standard dose of 1 tablet a day, which is 200 milligrams of Malarone a day. This needs to be continued only for 1 week upon coming back home, and can be started on the day or the day before leaving. Basically, it works as a schizanticide, working on the parasites in the liver. The other possible choice would be doxycycline, which is effective at a dose of 100 milligrams a day. Again, this needs to be continued for a week upon return. It's obviously cannot be used in pregnancy, women that are lactating, or young kids under the age of 11 years old. One of its considerations is that it can cause a photosensitivity when out in the sun. When we're there, I'll bet your temperatures are going to hit near 100. And then lastly, let's talk about methylquin as a prophylaxis. Basically, what's nice about it, like chloroquine, you only have to take it once a week. Its dose is 250 milligrams. But if you don't remember to take it the 2 weeks before you start, even though you're taking it once a week, it's got to be taken 2 weeks before departure, and needs to be continued for 4 weeks upon return. It has been known to cause some neuropsychiatric side effects, and should be avoided really in anybody with a neuropsychiatric history. It does produce vivid dreams, but they can be entertaining sometimes rather than feared. Let's end this long talk by discussing some of our concerns about precautions. Basically, because it's a nocturnal transmitting mosquito, covering up exposed skin in the evening will have some value. The use of insect repellents likewise are going to be of benefit. And then the use and education of people using synthetic pyrethroid and permethrin agents on netting, and using how to properly put them up can dramatically reduce the incidence of malaria. And then encouraging people when they're febrile to have their children or themselves tested quickly as possible for malaria, so that they don't get to that severe disease. I think for us, we need to consider Haiti as a possible unstable area because of even though it's endemic, it's got fluctuating incidence. Basically, what stable malaria occurs, this occurs when the transmission occurs for at least 6 months in the year and is intense. That's not going to be our situation. Malarial infection, when it's stable, is acquired repeatedly. Children suffer repeated attacks of malaria from the age of just a few months onwardly. Very young children are pretty much protected by passive immunity acquired by transplacental passage of a protective maternal IgG, but then they reach their own active immunity between the ages of 5 or 6 years, and they have substantial immunity. But the price of waiting to obtain this immunity, that some of these children will die of malaria before their immunity develops. The intensity of transmission, the availability of drugs, and the prevalence of effective drugs all affect the mortality in this stable malaria zones, where kids tend to be the big victims. When immunity has been established, older patients still suffer attacks of malaria, but we already said that these are mild to moderate flu-like episodes lasting a few days, and probably can go without treatment, except from the standpoint that they are vectors for continued spread of disease. Severe and complicated disease would rarely occur in these people. Malaria illness in adults does cause significant time loss from work, which is important to these people, and it can cost them 2 to 3 days' wages to get treated for this illness. Unstable malaria, in the situation we're going, there are wide changes in transmission, not only throughout the year, but also from year to year. The tendency for the epidemics to occur really causes it to be called an unstable malaria. The transmission season is typically short, and the mosquito population in Haiti fluctuates widely. Infection is usually not as frequent as in other endemic areas, and therefore people have the opportunity to develop, to lose a significant level of their immunity. For this reason, when transmission does suddenly increase, you're going to, because of some freak environmental condition, such as the earthquake, let's say, then people of all ages are going to become susceptible to the infection. This can result in serious disease now in all age group and not just our young kids. And that's what I want to make the point on, is that we need to make the diagnosis and treat individuals because of that potential complication, and also knowing that all those infected remain vectors for others. Chloroquine, as I said, is cheap and inexpensive. Well, I'm sorry for the lengthy talk on malaria. It is our most important topic. I hope that it was helpful. I know that rapid detection tests, if I can get a hold of someone, is going to be very useful to us. And look forward to us giving some education here to the people so that not only will they be protecting themselves from malaria, but other mosquito-borne illnesses by the use of nets and insecticides. And as a result, we'll have better immunity to fight off other infections. Thank you.